The menisci are semi-cartilaginous structures in the knee that can absorb synovial fluid. When subjected to increased load, fluid is expelled from both the menisci and the articular load-bearing surfaces, contributing to a phenomenon known as weeping lubrication. Additionally, as the menisci move away from the advancing condyles during motion, they help distribute a lubricating layer over the joint surfaces before contact occurs. This function is further supported by the large infrapatellar fat pad in the knee. The semi-mobile nature of the menisci allows the knee to operate as if it were highly congruent in terms of lubrication and stability, while also functioning as if it were incongruent during various joint movements. The critical role of the menisci in maintaining knee health and functionality is well documented. Their primary functions include protecting the underlying articular cartilage. 1. By expanding the contact area between the femur and tibia, the menisci reduce the load per unit area on the articular surfaces. Complete removal of the menisci decreases the contact area by 50%. 2. The menisci distribute central compressive loads toward the periphery, further alleviating pressure on the articular cartilage. 3. In full extension, 50% of the compressive load in the knee is borne by the menisci, increasing to 85% when the knee is flexed at 90 degrees. Deepen the tibial fossa. Enhance congruency between the tibia and femur. Provide stability to the tibiofemoral joint. Offer shock absorption and lubrication to the knee. Reduce friction during movement. Improve weight distribution across the joint. The medial meniscus is larger and has a C shape. It is firmly attached laterally to the medial collateral ligament and the fibrous capsule, the semimembranosus muscle, and the medial meniscopatellar ligament. The lateral meniscus is smaller and more circular in shape. It is attached to the popliteus muscle, the lateral meniscopatellar ligament, and the meniscofemoral ligament. Meniscal motion is influenced by soft tissue structures. The medial meniscus is pulled posteriorly during flexion by the semimembranosus muscle and the ACL, while it is pulled anteriorly during extension by the medial meniscopatellar ligament. The MCL and fibrous capsule also help stabilize it. The lateral meniscus is pulled posteriorly during flexion by the popliteus muscle and anteriorly during extension by the lateral meniscopatellar and meniscofemoral ligaments. During extension, the medial collateral ligament tightens, which causes the medial meniscus to stop gliding, while the lateral meniscus continues to glide forward. This results in internal rotation of the femur, which is equivalent to external rotation of the tibia. The menisci move with the tibia during flexion and extension, and with the femoral condyles during internal and external rotation. The medial meniscus moves approximately 6 mm, while the lateral meniscus moves about 12 m. During isolated tibial rotation, the menisci move in opposite directions. With tibial internal rotation, the medial meniscus moves anteriorly, and the lateral meniscus moves posteriorly. Meniscal injuries are common in sports, especially among athletes in soccer, football, and basketball. The meniscal injuries are caused by a combination of forces, including tibiofemoral joint flexion, compression, and rotation, which create abnormal shear stresses on the meniscus. Tears are classified as traumatic or degenerative. Traumatic tears occur in young, active individuals, often with rotational forces on a flexed knee. They are frequently associated with ACL tears and include vertical, longitudinal, or radial tears. Degenerative tears occur in older patients, over 40, without a traumatic event. These tears have limited healing potential and often involve horizontal cleavage, flap, or complex tears. The menisci in the knee can sustain various types of tears, including bucket handle tears, longitudinal tears, radial tears, horizontal tears, flap tears, and complex tears. Among these, the bucket handle tear of the medial meniscus is the most prevalent. This specific type of tear often results in difficulty fully extending the knee, while knee flexion typically remains unaffected, particularly in the absence of significant swelling. Traumatic tears of the medial meniscus usually involve the posterior segment and often extend in a longitudinal direction. Recurrent injuries to the same meniscus can cause the tear to progress further anteriorly, allowing the lateral portion of the torn meniscus to flip into the central intercondylar region, thereby forming a bucket handle tear. This creates a mechanical blockage that prevents complete knee extension, causing the knee to lock. Attempting to force the knee into full extension in this state can lead to further damage to the meniscus or excessive stretching of the anterior cruciate ligament. While less common, bucket handle tears can also occur in the lateral meniscus. Symptoms include joint line pain, clicking, locking, effusion, popping, knee instability, limited flexibility, and knee instability. Catching. Patients often describe catching as a transient sensation that does not require manual correction. This symptom is more commonly associated with extensor mechanism disorders, e.g., patellar maltracking, or small meniscal tears. Unhappy triad. This refers to an injury involving the medial collateral ligament, anterior cruciate ligament, and medial meniscus. It typically results from valgus, flexion, and external rotation forces applied to the knee when the foot is planted. Diagnostic tests. MRI is commonly used but may not always detect tears. Clinical examination and special tests are essential. Special tests include McMurray test, Apley test, Anderson medial lateral grind test, O'Donoghue's test, Bowler test, Payer test. Additionally, flexibility tests for the hamstrings, quadriceps, and Ober's test should also be performed. Differential diagnoses include bone contusions, plica syndromes, chondral damage, and patellofemoral pain. Meniscal healing. In 1936, King noted that a connection to the peripheral blood supply is essential for meniscal healing. Meniscal tears in the peripheral region can heal through two pathways, extrinsic and intrinsic. Extrinsic pathway. When a meniscal tear occurs, a fibrin clot forms within the tear margins, creating a scaffold for angiogenesis from the perimeniscal capillary plexus. The clot contains growth factors like platelet-derived growth factor and fibronectin, which attract and stimulate reparative cells. Undifferentiated mesenchymal cells migrate into the clot, forming a fibrovascular scar that gradually seals the tear. An inflammatory response and angiogenesis follow, leading to healing within about 10 weeks in animal models. Over time, the scar tissue transforms into fibrocartilage, resembling the original meniscus, though it may remain more cellular and vascular. Intrinsic pathway. Chondrocytes within the meniscus have an inherent ability to initiate healing, even in avascular regions. The fibrin clot aids this process by acting as a scaffold and providing chemotactic and mitogenic stimuli to promote repair. Arnottsky and Warren, 1982, provided a detailed description of the microvasculature of the menisci. In children, blood vessels permeate the entire meniscus, but this vascular penetration decreases with age. In adults, the blood supply is limited to the outer 6 mm, about 1/3 of the meniscus width, where healing potential is highest. Healing potential significantly diminishes as tears move away from this peripheral region. The type of tear also influences healing. Longitudinal tears heal better than radial tears, simple tears better than complex ones, and traumatic or acute tears heal better than degenerative or chronic tears. Tears in the vascular outer, 25-30% of the meniscus are repairable, as are tears extending into the avascular region if vascularity is stimulated. Physical therapy goals and interventions include reduce pain and inflammation using modalities, soft tissue massage, and manual therapy techniques like joint oscillations. Correct muscle imbalances and biomechanical faults through strengthening, endurance, coordination, and flexibility exercises. Address joint restrictions with targeted joint mobilization. Progress to functional training based on the patient's occupational or recreational goals. ACL stability is a critical factor influencing repair outcomes. Severe damage or meniscal loss can lead to joint instability and degenerative joint disease, potentially requiring joint replacement. Surgery. Medications. Acetaminophen for pain. NSAIDs for pain and inflammation.